Good morning to one and all, and thank you for the kind introduction. The topic for today is dopamine to dependence, the pharmacology of substance abuse. So, I would like to start the session with a statement that is carrying the essence and the gravity of the problem of drug abuse. The abuse of drugs is not just a personal tragedy, it is a public health emergency that erodes communities, burdens health systems, and steals future. Now, today in my session, I'll be exploring the pharmacology behind this crisis, how some substances are affecting the brain in a way that it becomes difficult to escape from them. Now, I shall be covering the topic under the following headings. First, we'll have a brief introduction to substance abuse. We'll have a brief overview of neurophysiology of substance abuse. This is already covered in the previous session, but as just as a connector to my core area, I would like to have a brief introduction or an overview of the neurophysiology of substance abuse. Then the main focus will be on the pharmacology of drugs of abuse. Now, let us understand what is substance abuse. It refers to the intentional, persistent, excessive use of a substance unrelated to medical or social norms, usually for its psychoactive effects that leads to physical, psychological, legal, or social harm to the user or the others. Now, when we refer to substance abuse, we can refer to any substance which is used in a harmful manner. For that matter, it can be like the caffeine or the prescription drugs like the sleeping pills, like the benzodiazepines or the barbiturates, or the socially acceptable and legally permitted alcohol or nicotine. But in today's session, my focus will be on illicit or illegal drugs because of their high abuse potential, their imminent dangers, and moreover, because of the escalating drug use in our country and the recent steep and alarming rise in Kerala, which has led to a lot of crimes in the recent past. So, and Kerala, we all know, was untouched by this menace for so many years, but now it has now become a hub of the substance abuse. Now, what exactly happens when a person is abusing drugs? So there are some profound changes in the brain that result in mainly two phenomena. That is, one is dependence, and the other one is the reinforcement. So let us understand what each one of it means. So first, let us understand dependence. It is a state where the body and or the mind, after the repeated use of a substance, starts to rely on it, making it hard to function without it and leading to repeated use despite knowing the harmful consequences. Now, the dependence can be again classified into two types. That is, one is called as a physical dependence, and the other one is called as a psychological dependence. And as per some of the textbooks, the psychological dependence is also referred to as addiction. Like what we call addiction is actually the psychological dependence. There's again some kind of difference between textbooks, but for this session, I am sticking on to this classification, that is physical dependence and psychological dependence, otherwise called as addiction. Now, physical dependence, that is an altered physiological state. In the case of psychological dependence, there is an altered emotional state in the drug abuser. Now, in the physical dependence, the body is becoming adapted to function normally only in the presence of the drug. However, in the psychological dependence, the person is believing that he or she can be in the state of well being or only if the drug is there in the body. Now, what happens in physical dependence on discontinuation of the drug? It is characterized by very distressful physiological or physical symptoms, which is referred to as the withdrawal symptoms. And these withdrawal symptoms are usually opposite to that caused by the drugs or the effects caused by the drug. And in this case, on the other hand, in the on discontinuation of the person who is having psychological dependence, you will not see physical symptoms. You will see more of psychological symptoms like depression and intense craving. And that intense craving leads to a drug seeking behavior. There is no withdrawal syndrome. On the other hand, the physical symptom dependence, there are physical symptoms, distressing physical symptoms, but there are no psychological symptoms. So there's no drug seeking behavior is not prominent. The drug seeking behavior is there in both the conditions, but it's more prominent in the psychological dependence and less prominent in the case of physical dependence. Physical dependence, the person is more like he's more distressed because of the physical symptoms that appear after the discontinuation of the drug. Now, this physical dependence is usually severe, but it is short lived. Psychological dependence is not very severe, but it is kind of persistent and prolonged. On the now, when we talk about the type of drugs which show physical dependence, the CNS depressants they show more of physical dependence, and the CNS stimulants they show more of psychological dependence. Now, when I say that these drugs show the respective dependence, it doesn't mean that they don't show the other one. Like for example, the CNS depressants they mainly show physical dependence, but they can also show psychological dependence. But the prominence is of that of the physical dependence, and the in the case of CNS stimulants, the prominence is for the psychological dependence. Now, what is reinforcement? Now, reinforcement is the process of repeating the drug use due to a consequence that follows it. It explains why individuals continue using a drug. Now, there are two types of reinforcements. One is called as a positive reinforcement. Here, the drug use is repeated because of a pleasant sensation that is experienced after the drug is consumed. For example, a person is consuming a drug, he experiences like euphoria or some kind of pleasure. So, he has a tendency to use it, like he's having a positive reinforcement to use it. Now, what is negative reinforcement? The negative reinforcement, in this case, the drug use or the behavior is repeated to remove an unpleasant sensation that occurs on discontinuation. Now, this can be well explained by the withdrawal symptoms that is seen in the case of CNS depressants on discontinuation of the drug. Now, the symptoms are so distressing that the person has to like use a drug again to avoid or to overcome those distressing symptoms. So in both the cases, there is reinforcement, but in one case, the person is taking it for the pleasure. The other one, that is negative reinforcement, the person is continuing the drug to avoid the unpleasant sensation that occurs on its discontinuation. Either way, the person is continuing to take the drug. Now, let us understand the neurophysiology of dependence and reinforcement. The key neurotransmitter, as you've already seen in the previous session, is dopamine. Now, there are four technically dopaminergic pathways, but when we talk about dependence and reinforcement or drug abuse in general, the pathways which are mainly important are the mesolimbic pathway, which you already know, means mediating reward, pleasure, and reinforcement of the behavior. And the mesocortical pathway, which is mainly mediating the decision making power and the emotional regulation in a person. Now, what happens in the case of drug abuse patients? Now, here the mesolimbic pathway becomes hyperactive in drug abusers. That is, there is an intense dopamine rise in the mesolimbic pathway. And when I say there's an intense rise, it doesn't mean that it's just like a very small rise. Okay, for example, you have a burger and that gives you a reward because there's some amount of rise in the dopamine which tells you like you like that sensation or you like the feeling, you like the taste. So you type next time you go to the same shop, you have that feeling, okay, you have the same burger. But in the case of drug abusers, this is so very high. Dopamine is so very high. It gives you a feeling of euphoria. An intense craving is there. Okay, that you will not wait for the next visit to the shop. You have to like have it very very fast. There is so intense craving, and that is like a positive reinforcement because of the cravings. Now, the mesocortical pathway, which was supposed to be helping you to make the correct decision, is underactive. That is, dopamine levels are low in the case of drug abusers. Now, so what happens? There is a poor decision making power, there is loss of impulse control, and the person is not able to stop himself from the drug seeking behavior. So, what we can say in simple sentence is that an overactive mesolimbic pathway drives the pleasure, followed by the cravings and the drug seeking behavior. The mesocortical pathway, because it is having an impairment, it reduces the brain's ability to resist the craving. So ultimately, the person is going seeking for the drug. Now, let us understand the dependence and reinforcement completely once again. So, on initial use, there is intense dopamine rise in the mesolimbic pathway that gives intense euphoria, and the reward signal teaches the brain that it is worth repeating. That is, there's a positive reinforcement. Then, when the brain is continuously, I mean, the person is using it continuously, so the brain undergoes neuroadaptation. So our body has a tendency that whenever something goes up or down in our body, it tries to again reset the homeostasis. So again, here the brain is trying to reset the homeostasis by downregulating the dopamine receptors and reducing the dopamine synthesis. Because you know that the dopamine is at a very high level in the body. So brain is trying its bit to decrease the dopamine synthesis. Now, at this point, the person is not able to enjoy any kind of pleasure because uh, a small stimulus will not do or give him the pleasure. Even the normal doses of the drug that was initially giving him the pleasure will not be able to give him the pleasure when this neuroadaptation is happening. So the person has to take more amount of drug. He has to take a higher dose of drug, and this is called as tolerance. Okay, so tolerance means it's the requirement of a higher dose of a drug to get the same effect which was initially giving you the that required effect. Now, on chronic use, dependence develops. Either it can be the physical dependence or the psychological dependence. Now, if the physical dependence is there, the person has craving, he goes for drug-seeking behavior. Now, again, it's psychological dependence. Withdrawal symptoms are there. Again, person goes after the drug because he wants to avoid the distressing symptoms. So, over time, the drug becomes both the cause and the cure of the distress. So now let us go to the classification of drugs of abuse. So they are mainly classified as CNS depressants. Now the CNS depressants are drugs which are slowing down the brain, which you make you calm, relaxed, and can cause drowsiness or sleepiness. Examples are opioids. Then there are CNS stimulants. Okay, and the CNS stimulants, again, they are the ones which stimulate the brain activity. They make you feel alert and highly energetic. Examples are cocaine, amphetamine, and methamphetamine. Now, hallucinogens are the ones that distort the perception of reality. That is, they cause hallucinations. Under this comes the LSD and MDMA. Then there is a set that is cannabis, is a CNS combination of CNS depressant action, stimulant action, and hallucinogenic action, and that is cannabis. Let us also look through the street names of some of the drugs because most of you would be knowing these drugs better by their street names because these are the names that usually we see in the Bollywood movie or a Hollywood movie is usually these street names. Okay, so I just go through them very fast. And again, we have the repetition when I deal with the individual drugs. So morphine, it's called as white stuff, God's drug. Heroin, you know, it's called as smack, brown sugar. Then fentanyl is used as called as China white, dance fever. Cocaine is coke, snow, blow, Charlie. Amphetamine is bennies, uppers. Methamphetamine, often referred to as meth, crystal, ice, glass. LSD called as acid, Lucy, blotter. MDMA is called as EX or ecstasy, Molly, Adam. Cannabis is known by a number of names in the form that it's used. Different forms of cannabis is available. A number of names are available for that. Again, weed, pod, grass, ganja, charas, hash, black stuff, and all. Again, there are regional names are there for all these drugs. Now, these are some of the street pictures showing how these drugs are packaged and sold on the street. So you can see these are called as the LSD blotter tabs. So each one you can see here, this is like each one is a tab. You can see beautiful pictures on these tabs. Okay, these are taken up orally and kept on the tongue. And this is the MDMA tabs. You can see how attractive these are with emojis. The cannabis is having a rolled joints. Cannabis is having, like, you can see this is joints which are having cannabis dried and crushed inside them. And this is heroin baggies, and this is the beautiful crystals are of methamphetamine. Now, the paraphernalia that is used to to assist in the use of these drugs, burnt spoon and syringes for opioids. This is a grinder for cannabis. This is a traditional chiller pipe which is used for again for cannabis and hashish. These are bongs for cannabis. This is a glass pipe specially meant for methamphetamine, then inhalation, and these are the e-cigarettes or the vape pens. Now, e-cigarettes is a modern terminology, and it is actually they are battery operated devices which are heating the liquid into a vapor that can be inhaled. Though, and cannabis is one drug that is available as e-cigarettes. And now this is often commercially advertised as being the safe alternative of the cigarettes and all. But again, they carry their own risk, and it cannot be trusted. All these advertisements are not trustworthy. Before we go into the individual drugs, let's just have a fair idea about what is the danger score of these illicit drugs. Okay, the topping the list are the opioids like fentanyl and heroin, followed by the CNS stimulants like methamphetamine and cocaine. The other opioid like morphine and the other the stimulant amphetamine is somewhere midway, and the least toxic ones, or I cannot say the toxic one, the least dangerous ones among this group is probably the LSD and the cannabis. Okay, so that is the danger scores of the illicit drugs. Now we start with the CNS depressants. So under this, we are having opioids. So the examples of opioids are morphine, heroin, which is actually diacetyl morphine, and fentanyl. When we compare their sources, morphine is actually a natural one which is obtained from the latex of the poppy plant. It was first actually isolated by Sir Turner, and he had called it morphine because from the name of the Greek god Morpheus, Greek god of dreams, that is Morpheus. Okay, and most of them are like the commonest root is IV, and heroin and fentanyl are even smoked also. When we talk about the potency, heroin is 2 to 3 times more potent than morphine, and fentanyl is the most dangerous. It is about 50 to 100 times more potent than morphine. Now, I told you already that it's coming under CNS depressant. So, the opioids are going to act on a lot of areas on the brain and depress that. It's acting mainly via the mu opioid receptors. It binds to various areas in the brain, controlling pain, consciousness, respiration, and decreases the neuronal excitability, and thus brings down the CNS, causes a CNS depression in the form of analgesia, sedation, and all. Okay, but now what exactly is like? Why are the addicts actually? What is the mechanism of action, or what is the reason why the addicts are using this morphine? This is explained by the binding of the opioids to the mu opioid receptors in the mesolimbic dopamine pathway. So once they bind to the mu opioids there, what they do is they inhibit the GABAergic interneuron. The normal function of the GABAergic neurons is to decrease the dopamine release. Okay, but now what is happening is that there is inhibition of the GABAergic interneuron, and because of that, there is a disinhibition of the dopamine release. That is, the dopamine release is increasing. So here's an indirect activity on the release of dopamine. And that, once dopamine release is increased, you again end up with euphoria, reward systems, and again the drug abuse continues. Now, what are the opioid effects? Now, the desired effects that is the effect that is desired by the addicts, is obviously euphoria. And this is referred to as high or kick. And that this high or kick is obtained by the fast IV injection. Now, what is this high or kick? It's a pleasurable sensation in the abdomen, or it is like a flushing sensation on the skin, that is usually akin to orgasm. Okay, and they feel, because of the CNS depressant activity, they have a prominent calming effect, that is reduced apprehension, reduce fear, reduce anxiety, and there is blunting of negative emotions like emotional pain, feeling of detachment, which is usually referred to as floating, and they are in a dreamlike state. That is meant, and there is mental clouding, inability to concentrate, and they are in a dreamlike state, and that is usually referred to as nodding. So when we are dreamy or when we are sleepy, we usually like do this nodding, right? You can see all these people in the classrooms nodding. But that is this condition, the dreamlike state, is referred to as a nodding. So you can see this picture of a nodding person, though it's not moving. And all these addicts, you will always see this marks, that is called the track marks on the skin. This is one of the identification of drug abusers. You will see linear injection marks on the superficial veins of the forearms. This is one of the indicators or the signs for any drug addict for that matter. The other effects are which are not usually desired by the addicts, but it has to come along with the use of the opioids, is excessive sedation, constipation, nausea, vomiting, itching, meiosis, hypotension, bradycardia, and respiratory depression, usually seen with toxic doses. Now, when we see the pharmacokinetics, this is very, very important. You can see that an IV dose of a morphine, it starts its onset of action in 5 to 10 minutes, whereas heroin and fentanyl, they are technically taking 1 or 2 minutes or even seconds in the case of heroin. So they're acting very, very fast. So whichever drug is acting fast, that drug has got a more higher abuse potential, because everybody wants the effect to be very fast. They don't want to wait. Okay, and the duration, when you look at the duration for morphine and heroin, it is 3 to 5 hours approximately. But for fentanyl, it's just 1 hour, under 1 hour. Now, the problem with fentanyl is that it is very potent. It brings out the onset of action is very fast. So that people, like, they tend to abuse it. But the problem here is that the duration of action is very short. There is a chance of repeat usage, and that can lead to toxicity. And that is one reason this fentanyl becomes very, very dangerous. Now, how can we identify the toxicity? Usually by the triad of meiosis, pinpoint pupil, respiratory depression, confusion, and coma. Now you can see I've shown you the toxic doses of morphine, heroin, and fentanyl here. You can see the fentanyl is toxic even in microgram doses, very potent. And now talking about the tolerance, this is a drug which develops tolerance. The person develops tolerance because he might be requiring increased dosages, higher dosages with continued use. Okay. Now, another implication of tolerance is that a naive person who is using these kind of opioids for a short time, that person can be this is a toxic dose, a lethal dose for that person. But for a person who has been chronically abusing the opioid, okay, for that person is tolerant. So even the lethal dose becomes a higher for that kind of a person. Let us talk about dependence now. Now, as I already mentioned to you, it's a CNS depressant, so it is more likely to develop physical dependence, yes. And physical dependence is always characterized by distressing withdrawal symptoms. And in this case, it is lacrimation, sweating, yawning. There's a lot of anxiety, fear, aggressiveness. There's mydriasis, diarrhea, rise in BP, and heart rate. Then you can see there is psychological dependence is there, and the person is having depression, restlessness, intense craving, and trafficking behavior. This part you will not see much. It is less prominent as compared to the physical discomfort that the person undergoes. Now, when you look at the opioid withdrawal timeline, you will see that the physical symptoms, they will develop within, you can say, 72 hours of the opioid withdrawal, and will be lasting there and will become less by 1 week. But the psychological symptoms, they continue beyond 2 weeks. They are not very intense, but they continue beyond 2 weeks. Now, what are the opioid detox methods? So, when you have a toxicity with opioid, the treatment is with naloxone given intravenously. Naloxone is an opioid antagonist, and along with that, you have to give the supportive measures. Naloxone would have to be repeated multiple times depending upon the dose that has been consumed by the patient. And the indicator is as when the respiration picks up, that is the indication till the point where you have to give naloxone IV. Now, withdrawal symptoms, clonidine and diazepam have been tried to alleviate the withdrawal symptoms. The de-addiction measures usually include methadone substitution therapy or long-term methadone maintenance therapy. Now, methadone is a long-active orally effective opioid. And the characteristic feature of it is that it is binding the tissues, it is acting very long, and it's something that is unable to give the person a kick. It's not able to give the kick that comes along with the use of a IV opioid. So, and when you stop this drug, the withdrawal is very gradual, it's not intense, and it is kind of prolonged. So what they do is they withdraw the opioid that the person was abusing and then substitute it with methadone. And this is continued, and slowly the methadone is taken off. Another, in the maintenance therapy, what happens is methadone, the sufficient dose of methadone is given, so that the patient develops tolerance that if he tries to abuse or use this IV, he will not be able to feel that pleasurable feeling or the high or the kick, and the subject will eventually give up the habit. Again, the psychological therapy, counseling, and rehabilitation is a part of de-addiction measures. Okay, now this is the example of the opioid crisis that USA has been facing. So in USA, there is a street called as in Philadelphia. There's a street like called as Kensington Ave, and here what happens is people abuse the drug where the heroin or fentanyl is mixed with a veterinary sedative called as xylazine. Now, the xylazine is very kind of produces skin necrosis, and you will find people who are in a trance-like state, non-responsive, with non-healing ulcers on their bodies. Just have a view of this. Okay, now let's shift to CNS stimulants. So that there we have here examples are cocaine, amphetamine, and methamphetamine. So first, let us look at cocaine. So it is obtained from the leaves of Erythroxylum coca, a coca plant which is native to South America. The forms which are usually abused are of two types. One is the cocaine hydrochloride, which is a white powder, which is either snorted or injected. So this is what is snorting, like taking in intranasally. And there is crack cocaine, which is the cheap freebase smoked one. This is the crack cocaine. And this is the example of an epidemic, which is referred to as the crack epidemic in USA. So what happened was there was extensive use of this cheap crack cocaine, and especially among the Black communities, and it had led to a lot of violent crimes and incarcerations in USA. And this has led to very harsh laws, and especially against the blacks. And even now, there is a debate on this, regarding the harsh laws that is targeted against the blacks. So the origin of these laws were the crack epidemic in 1980 in USA. Now, how does the cocaine act, and what is the link with the dopamine? Okay, so the cocaine here is blocking the reuptake of the dopamine. noradrenaline and serotonin into the nerve terminals by inhibiting their transporters. Their transporters, you can see here, noradrenaline transporter, then there is a serotonin transporter, a SERT and DART. So they are just inhibiting that transporters, and so the reuptake will not be there. So they are more available in the synapse for action. This leads to elevated dopamine in the mesolimbic pathway. So again, what will be the result? Euphoria and the reward system. Elevated noradrenaline will give rise to sympathetic symptoms like increased heart rate and BP. This is usually seen at higher doses. And again, there is elevated serotonin. Again, that can cause euphoria, agitation, and hypothermia. Again, you can see a lot of effect of the serotonin at higher doses of the cocaine. Now, let us study the effects of the cocaine. At low to moderate doses of cocaine, which can be obtained by snorting, smoking, or even IV, can see that the duration of onset is like very less. In case of smoking and IV injection, you get very instant, rapid, intense high. And the problem here is that with smoking or the IV injection, though the intense rush or the intense high is there, it is lasting only for a small time. This can lead to binging, again, repeat use, and that can lead to toxicity. Now, what are the toxicity that can occur is cardiac, resulting in arrhythmias, hypertension, myocardial infarction. Then you can have CNS and seizures, hypothermia, stroke, agitation, paranoia. And death is usually because of the cardiotoxicity or because of something called as the excited delirium, that is characterized by threatening agitation and hypothermia. Now, what happens, or what are the things that are seen usually with the cocaine use on a chronic basis? So, the characteristic feature, one of the things that is usually seen in most of the cocaine users is a nasal septum perforation because of the snorting that they do. And on long term, there can be psychosis and cognitive impairment in the user. Now, what are the other effects that we see in cocaine? So, there's a term called as a reverse tolerance. Now, what I mentioned in opioids was tolerance, but in case of cocaine, there is reverse tolerance. So, what happens here is that there is a paradoxical increase in the effect at lower doses. Now, that can happen with chronic use. There will be increased effect at lower doses itself. So, there is a chance of toxicity even at lower doses in chronic abuse. So this can be very dangerous, and this is one of the things that has to be educated and made aware in the chronic cocaine addicts. Now, dependence in cocaine, being a stimulant, is always psychological. That is more prominent, and the dependence we usually call, or we refer to it as crush in the case of dependence associated with cocaine. You see depression, anhedonia, intense craving, and drug seeking behavior. And because the intense craving, there can be dangerous activities because they want to somehow seek the drug that can lead to dangerous crimes also. Physical is less prominent, mainly characterized by fatigue, hypersomnia, body aches, and increased appetite. Let us look at the amphetamine. Let's see how it is different from cocaine. So this is a synthetic one. It's as compared to the natural cocaine. And when you see the onset and duration of action, as I already mentioned to you, cocaine has got a fast onset of action and it has got a short duration. And it produces a very sharp and very brief rush. Whereas amphetamine, by the IV route, it has got a faster onset, but it has got a longer duration of action, that is 4 to 6 hours than cocaine. And the rush is not very high. It's not very intense. It is very milder, less intense, but there is a prolonged stimulation. So there is a difference in the use of the type of use of the cocaine and the amphetamine. In the case of cocaine, you will have a binge use. Chances of toxicity is more binging because of binging. Whereas amphetamine, there is a sustained use. So there is not much chance of a toxicity there. Now, the case of dependence, in case of cocaine, the dependence occurs very rapidly. It is intense and it is of a short duration. Whereas in the case of amphetamine, it occurs gradually. It is not very intense and it is not leading to any kind of dangerous behavior. Okay, dangerous drug seeking behavior. Whereas the other one, it is dangerous drug seeking behavior is there. Now, we can always say that cocaine is like a Ferrari, fast and flashy, but burns out quickly, whereas amphetamine is like a train, longer journey with steadier high. Now let us see methamphetamine. It is often called as meth, crystal, ice, glass because of the crystalline appearance that it carries. It is often referred to as the amphetamine's evil twin because it is stronger, longer, and more damaging. Let us see how it does that. Now, when compared to amphetamine, it is more potent. It has got a faster onset. Now you can see the duration of action is much longer as compared to the amphetamine. It's about nearly 1 day. And the problem that we saw, or the deficiency that we saw with amphetamine, though it was longer acting and faster acting, the rush was not very intense. This one causes intense rush also. So the rush is intense, it occurs fast, and it's longer lasting. So it can lead to high drug addiction potential. Here, the crash is also more intense, longer lasting, and it can lead to dangerous drug seeking behavior. Now, this drug has to be very, very carefully handled because of these reasons. The toxicity can appear. Now, on the chronic use, the meth users usually develop meth mouth, which is characterized by severe dental decay. They can have formication, that is the feeling of tactile sensation of bugs crawling under the skin. But there is no bug in reality. So they just keep on itching and pricking. And because of that, they develop a lot of lesions, which is shown in the picture here. They can develop severe paranoia, hallucinations, psychosis, and there's a lot of neurotoxicity associated with the chronic use of methamphetamine. Methamphetamine is also called as a poor man's cocaine because it is producing intense rush, it is producing long-lasting rush, and it is cheaper as compared to cocaine because it can even be synthesized in home laboratories. Now, when we come to the detox methods of stimulants, there is no approved pharmacological detox for toxicity. Just supportive care has to be given for in the form of benzodiazepine for agitation or seizures and antipsychotics for psychosis. Rehabilitation remains the mainstay for as a de-addiction measure for the stimulant um, drugs. Now we come to the hallucinogens. Now, these are the drugs, as I told you earlier, they are the ones which are mainly concerned with distorting the perception of reality. Under this, first we'll deal with LSD. It's referred to usually as acid Lucy blotter. And this was first accidentally discovered by Albert Hoffman during his work with ergot alkaloids. And he had consumed it himself and described its psychedelic effects. He had he had described visual distortions and inability to concentrate and uncontrolled urge to laugh. This is how the Dr. Albert Hoffman had described the actions of LSD. Now, how is it obtained? It is a synthetic derivative from a fungus, Claviceps purpurea. The mechanism of action here, the primary action is on the serotonin receptor. Okay. The secondary action is on the dopamine receptors and the adrenergic receptors. So when we see the actions, the perception part, if its effect on the perception is more primary than the part caused by the dopamine, that is the euphoria and the other mood changes. The routes already we have shown you the blotter paper. It's available as a blotter paper for oral consumption, and it's also available as inhaled and IV forms also. The onset of action is nearly 1.5 hours, and duration is 8 to 12 hours. So again, there is not much binging or such kind of use associated with LSD because mainly this is not like a euphoric drug because the action on the dopamine is secondary. It's mainly a drug which is changing the perception of reality, cause giving you some hallucination. Now, any person on LSD can have either a good trip or a bad trip. That means a good sensation or a bad sensation. Now, what is a good trip? Good trip is a pleasant hallucination. Like when I say pleasant hallucination, it means like the person is visualizing some geometric patterns, beautiful faces, shimmering lights. He might be hearing some beautiful, pleasant music. And there is euphoria, there is elation, there is intense creativity. He feels connected with universe, and this will encourage him to consume more of the LSD. Whereas bad trips, the person is having terrifying hallucination. He might be seeing distorted images of monsters, blood, insects. He might be hearing mocking and laughing voices, and he may be also having tactile sensations. There may be intense paranoia. There can be severe depression. There can be fear of death, even being feeling like trapped or already dead. He doesn't feel connected with reality. There's depersonalization, and because of all this kind of terrifying and distressful symptoms, he feels like he wishes to escape that. So there's a tendency of suicide. He might just run into a moving traffic or jump from a height, and that can, in an attempt to stop this distressing experience. And when we talk about LSD, thankfully, there is not much of a dependence. Even if there is a low psychological dependence. Otherwise, we can always say that it has got nil dependence. On chronic use, some users may develop frank psychosis. And there's something called as a hallucinogen persisting perception disorder associated with the chronic users. Now, this is the flashbacks or the hallucinations occur even for 5 years after stopping LSD. That is called as the HPPD syndrome. HPPD. This now, when we talk about the toxicity or the risk of the LSD, we should understand that there is the danger of LSD is not lying in the pharmacological toxicity, because there is not much pharmacology toxicity. The problem lies in its powerful alteration of the perception, and that which leads to the person going and committing suicide, mostly tied to the bad trips. Otherwise, the pharmacological toxicity is not the one that is associated with the deaths associated with the LSD use. Next is MDMA, often referred to as ecstasy and Molly. Now, this is again a synthetic derivative of amphetamine, and the abuse of this MDMA now in Kerala. This is supposed to be one of the most seized drug in Kerala, and it is mostly seen in youth, in college students, even young professionals who are having like a party and nightlife scene. See, now root, I've already shown you, they are available as very attractive oral tablets, and these are having emojis. So you cannot differentiate with from the candies that the children might be taking. Okay, so it's available in that form to attract the people. Now, mechanism of action, just like I told about the LSD, this is also mainly acting on the serotonin, dopamine, and any levels, and I mean the adrenergic noradrenaline level, and distorts and changes perception, mood, and energy in the same way like what we have seen in LSD. One more thing that is additional in the mechanism of action is that it increases the oxytocin release. And this is what increases the bonding feeling when somebody is taking the ecstasy. So that is why MDMA is also referred to as an empathogenic drug. Okay, now what happens when somebody is taking the ecstasy? So you can see it produces dose-dependent effects. So as far as the point when somebody is taking up to 125 milligram of the dose, he might be having euphoria, sociability, that is sensory enhancement, there's emotional bonding, and that is why it is also referred to as a hug drug. Above 150 milligrams, the hallucinations start developing. There's jaw clenching, panic, hypothermia, and agitation. Above 200 milligrams, there is frank serotonin syndrome characterized by confusion, hypothermia, tremors, clonus, leading to rhabdomyolysis, hyponatremia and cerebral edema, agitations, seizures, cardiac arrhythmias, and sudden death. Now, this is the part that most of the people who are abusing the drug do not know. This is the area that is usually promoted. That is the feeling of euphoria, sociability, sensory enhancement, emotional bonding. That is the point that is usually advertised, or I mean, by the drug peddlers. But what they don't understand is that when they go for a toxic dose, it can lead to even sudden death. Now, somebody who's using chronic repeated MDMA can end up with anxiety, depression, memory impairment, sleep issues, and neurotoxicity. Dependence, luckily, is not much. It's even if it is there, it is a moderate psychological dependence. So what we observe is that physical dependence was mainly prominent in the CNS depressants like the opioids, whereas in the case of CNS stimulants and in hallucinogens, we more see more of the psychological dependence, and that also more in the stimulants and relatively very less or nil in the case of the hallucinogens. And this is a picture, the video which shows a person describing the serotonin syndrome. Okay, so now why is this MDMA becoming so popular? First thing, it is perceived as safe and clean as because there's no injections or smoking involved. There's tablets, and there are also beautiful emoji coated tablets. It's an empathy drug and promotes a bonding and openness, sociability at parties and nightclubs. It's easy to conceal and transport as pills, powders, courier packages, and it's at available via the dark web. Okay, so the online markets are there, which are buying and selling these drugs through encrypted the sites like the Tor, and also using cryptocurrencies like the bitcoins, even the social media apps that we're using so frequently, the Instagram, and very notoriously the Telegram and the Snapchat. All these have been accused of being involved in the buying and selling of these illicit drugs through various reports and documentaries. Again, there is low awareness, as I've already told you, there is low awareness of the toxicity risk. Many still believe it is a party pill. So, as long as the dose is up to 125 milligram, they can definitely use it, definitely conceive it as a party pill. But once it goes to the higher level, they end up with toxicity, even sudden death. So that has to be educated. That has to be, people have to be made aware of the toxicity of the MDMA. Now we come to the last bit, that is the cannabinoids or the cannabis. Now, cannabis is having a lot of names, okay, and it is based on the different forms that are available for cannabis. The source is cannabis sativa plant. The psychoactive ingredient is tetrahydrocannabinol, THC. And the forms of abuse, marijuana, which is usually referred to as a weed, pot, grass, ganja, Mary and this is dried leaves and flowers which are smoked or eaten, and it contains about 5 to 20 percentage of THC. Then there is hashish, which is referred to as charas, black or stuff, and it is more concentrated. It is usually smoked, and it contains more percentage of the THC. Then this is the hashish, which you are seeing it from the very famous Bollywood movie. Zeenat Aman is actually using that is like smoking the hashish through that traditional chiller pipe. And then hash oil is very potent, and it is vaped or dabbed. Vaping means just creating vapors, right? And dabbing is like you create very intense vapors using blowtorch, which is very, very dangerous. And this is usually vaped or dabbed, and can be very dangerous in that sense. Then there is bhang, which is a traditional Indian preparation from crushed cannabis leaves and flowers, and it's usually mixed in milk or food, and is consumed during festivals like Holi. This is again a scene from Bollywood where you can see Rajesh Khanna offering the bhang to some actress. Now, let us see the cannabis. Now, I have put a picture of the chameleon here. Now, this is cannabis is often referred to as a pharmacological chameleon because it has got different actions at different doses. It can be a stimulant, it can be a depressant, and it can be a hallucinogen also. Okay, let us see how it does that. So, at low doses, it's basically a stimulant. It'll bind to the cannabinoid receptor CB1 in the mesolimbic pathway, decreases the GABAergic interneuron, and just like the opioids, it is causing a disinhibition of dopamine neurons. In an indirect way, it is affecting the dopamine, and it is also increasing the noradrenaline release in the periphery. So all this is ending up with mild euphoria, increased sociability, talkativeness, and increased heart rate because of the adrenaline effect. Then, at moderate to high dose, it behaves like a depressant. Now, here, the CB1 activation is occurring in the cerebellum, basal ganglia, the reticular activating system, and decreases a excitatory neurotransmitter, glutamate, and that leads to relaxation, sedation, there is motor slowing, and there is impaired motor coordination. At very high doses only, it shows the hallucinogen effect because of the CB1 activation in the cortex and the limbic system and the modulation of the serotonin pathways. Now, that can end up in lead to actions like distorted time perception, hallucinations, both visual and auditory, then some kind of paranoia, anxiety, and psychosis. Now, so these all depend upon the concentration of the THC that the person is taking. Okay, so at a high dose, usually the person will be having more of a hallucinogen. Now, something very good or a good news about cannabis is that it doesn't have any fatal overdose is not known. What the risk is that because the motor coordination, in coordination that we have seen in the case of high to moderate dose, the people can end up with some injury or accident risk. That is the main concern with the cannabis. So when I showed you the danger categories of the drugs, I've shown the cannabis as the last one. There's a reason because no fatal overdose has been still reported with the cannabis. On chronic use, obviously, it impairs the memory, attention, and learning. It's like creating a motivational syndrome in the chronic users. When the dependence, again, there is only psychological dependence, that also very low to moderate psychological dependence is there. When we talk about detox methods, again, there is no pharmacologically approved detox methods. Abstinence is the one that leads to symptom resolution in weeks. And again, rehabilitation meditation measures and the methods of through behavioral therapies is that is advocated for cannabis detox. Now, let us go to the last bit, mention about the club drugs. Now, this is not a pharmacological category. This is only a context-based category. It just includes the drugs which are used commonly in party settings like nightclubs, raves, music festivals to enhance the mood, the sensory perception, sociability, and sexual arousal. So this includes all the drugs that I have already mentioned to you: MDMA, LSD, cocaine, amphetamines, and methamphetamine. Besides these drugs, there are others also like ketamine, GHB, and flunitrazepam. Now, ketamine, as you already know, is a dissociative anesthetic which is used in therapeutics. It can cause a floaty feeling, it can cause hallucinations, and sometimes a total unresponsiveness, which is called as a K-hole. GHP is very risky. It's called as a liquid ecstasy. It causes relaxation and mild euphoria, sociability, and increased libido. But the problem is that it has got a very low safety margin and can end up with coma, respiratory depression, with slight increase in the dose. Flunitrazepam is a benzodiazepam, and it can cause heavy sedation, antegrade amnesia. Now, because these drugs like GHB and roofies are colorless and odorless, they can be easily slipped into the drinks, and they are one of the reasons why, which has led to a lot of sexual assault, the cases of sexual assault at such kind of events like the nightclubs and all these raves and music festivals. Now, let me talk about the designer drugs finally. So, these are the laboratory made substances which are designed to imitate the effects of the illicit drugs. Now, what is done is that the chemical structure of these illicit drugs are deliberately modified in order to avoid the legal classification as illegal, to evade the standard drug test, to remain unregulated, at least for temporary, till the time that they are caught. And these are always sold online or in the clubs, or they're marketed as bath salts or herbal incense or research chemicals with misleading labels like not for human consumption. Okay, now what the problem with this is that the potency of these drugs and the toxicity are unpredictable. They can be more harmful than the drugs they mimic because they have not undergone any sort of testing on safety, and we do not have any kind of literature describing their safety profile, and they have been often associated with severe psychiatric symptoms, overdose, and death. Now, I have shown you here the picture of Dabba Cartel. This is a Netflix series, and this is a special, suggestion for Netflix addicts. They can watch Dabba Cartel, where they're talking about designer drugs. Okay, and in a very beautiful and the storyline contains designer drugs, where these women are selling drugs, and they are not selling the normal drugs. They are selling drugs after chemically altering the available illicit drug by mixing coloring agents and other things. Okay, I don't want to tell the story here. Those who are interested to know more about designer drugs in a fancy manner, you can always watch the Dabba Cartel on Netflix. Okay, now the summary. So in this session, we have discussed about the substance abuse. We have talked about the role of dopamine in dependence and reinforcement. We talked elaborately on the pharmacology of illicit drugs. And finally, we had a note on the club drugs and designer drugs. So with that, I come to the end of my session. So the final word, falling into drugs is easy, climbing out is the battle, but with hope in our hearts and hands held tight, we can lead them back to life. Thank you. These are my references.